Hi, everyone, and welcome back to another edition of Public Health Career Conversations. I am pleased to have with me today Associate Professor Nandi Siegfried. Nandi is a public health medicine specialist in South Africa, and she works in the role of independent clinical epidemiologist, as well as part-time in the role of a chief specialist scientist at the Medical Research Council in South Africa. So Nandi, thank you for joining us today and for giving your time to share some of your insights around your career. So I really have just a few questions. It's basically about you. And what I really want to know, I think what most people want to are grappling with and would like some insight around is like, how does somebody come to the decision to pursue public health? What are some of the decisions around it? What are some of the factors that may have led to you pursuing public health? So if you could maybe just talk me through that.
Okay, thanks very much. I think if I look back on my career, a lot of it at the time didn't feel intentional. But there is actually a straight line of, proceeding forwards in the public health space. I grew up in the 1980s, so I matriculated in the late 80s, which was a very turbulent time in South Africa. And one of the things I think that I was very aware of, even before going to medical school, was the social dimensions of health. It was very obvious if you chose to see it in terms of who had access to good healthcare and who didn't. I think my first real entry point into thinking about public health as a career was at UCT. In our fourth year at the time, we did a paltry 5 weeks of what was called community medicine. Most people didn't want to do it. And part of that, we were assigned as you were in couples, and we were assigned to a registrar who would have been a community medicine registrar at the time. And we had to participate and produce a mini project. And the registrar I was working with was looking at TB notification rates. And my partner and I spent maybe 2 weeks in the bowels of Groote Schuur in the medical record department. And I remember we had two months where what we needed to do from September to October was pull all the discharge files of individuals who'd been diagnosed with TB and then see how many of them actually had a completed TB notification form. And if memory serves, it was between 20 and 30% had actually been formally notified. And I remember the registrar being very shame, I can't remember his name now, but being this was really very good data that we'd collected. We'd been very consistent about it. And I thoroughly enjoyed counting all of the discharge summaries and looking for all the data in what was essentially a basement of Groote Schuur Hospital. And I think I was so profoundly shocked at how few notifications were actually happening. It became immediately apparent why we saw so many people with TB and why really the system wasn't working as well as it should. And then I think the next really eye-opening point was I did my internship at Katatura Hospital, which is part of the Windhoek State Hospital complex. And in the first 2 weeks, my first 2 weeks of internship, I was assigned to the gastro ward in the pediatrics. And by the end of those 2-week periods, some of the babies and small children who we discharged at the beginning of the 2 weeks that I'd been in there were coming back into casualty. And I realized that there was nowhere to send them for follow-up. There was no nutritional support. The system was not working outside the hospital. And I think that really opened my eyes to the fact that what I was interested in was stopping people getting to the hospital. And so I think that's very, perhaps, simplistically, was the beginning of where things started for me. I then really, when I said things weren't intentional, found myself in various different locations around the world working. And at one point, about 5 or 6 years later, I was living in Sydney, and I'd been working clinically in one of their big hospitals, the Royal Prince Alfred Hospital. But at the time, as a South African, you needed to write exams to get your medical qualifications recognized. I had gone across on a trainee program, which waived that requirement. But I then wanted to continue moving forward and applied for residency in Australia, residency to actually live as opposed to the American version of residency. And at that point, Tia, what happened was suddenly I wasn't able to work clinically. And it was going to be a year. It ended up being 2. But during that time, I was fortunate to find within the hospital where I was working what was actually a health management program, which very quickly, in consultation with the consultant I'd been working with, we managed to rejig as having a research component. And I very quickly learned that I knew nothing about research. I had absolutely no data skills other than being able to count little pink forms in Groote Hospital. I don't think I'd really even heard the study design of, I don't think I could have explained to you what the difference between a randomized controlled trial was and a cohort study and comparative studies. I just didn't have any of that. And of course, I think we did applied statistics in first year, so there was no way that I was going to remember any of that. And suddenly I realized I needed to upskill. And I applied and began a master's in public health at the Sydney University, Faculty of Health Sciences, and that would have been in 1998. And it was a 2-year part-time program, so it was 4 hours twice a week, Mondays and Wednesday nights. It was very intense, and I had the most marvelous epidemiology lecturer. Interesting enough, the head of epidemiology at the time was someone called Professor Les Erwick, who was actually one of the leaders in public health and epidemiology at the South African Medical Research Council before he'd immigrated to Sydney. And I literally realized that this was what I wanted to do. I was so fortunate because the data that I was sort of collecting and the project that I was working with at Central Sydney Area Health Services both overlapped with that type of just epidemiological data, but there was also a component which I was then able to use for my master's thesis around qualitative evaluation of a particular health service. And so I was actually almost learning on the job as I went. And I did that for 2 years. And then we came back to South Africa. And at that point, I had my medical degree and I had my master's in public health from Sydney University. And it would have been early 2000. And I was asking, I think, the question that probably a lot of people who are doctors then ask, do I need to do anything in addition to an MPH? I've already done some of these skills. I had originally got a contract job at the Medical Research Council, and that then turned into a permanent job. I was working at what was called the Cochrane Centre at the time, which was part of the larger Cochrane collaboration where we look at evidence synthesis. And I was very involved at that stage in all of the debates and discussions that were being had around TB treatment and HIV treatment and antiretrovirals in the early 2000s. So it was a very vibrant public health space. But I really sat for a few years with whether or not I needed, as a doctor, to go and do the college exams. And I felt at the time that my skills were probably no less from an MPH point of view. I felt that I had good skills that I'd gained at Sydney University, but I wasn't as familiar with the South African health system as I could have been. I didn't really know much about health service management. And at the time, and I know things have changed since, at the time, if you did the college at UCT, if you enrolled as a registrar, you also needed to do the occupational medicine diploma. And I was quite interested in that with the interface of work and so on. So I went to speak to Rodney Ehrlich and Johnny Myers and Leslie London, who were running the program at the time. And I was able to get a year back credited towards my registrarship from the 2 years work that I'd done in Sydney. I was in Sydney for 4 years. So the first 2 were clinical, the second 2 were non-clinical work. I really enjoyed having to do the diploma in occupational medicine, and I joined the occupational medicine clinic 1 day a week, which I was able to do as what I was termed then a supernumerary registrar. So I actually maintained my job at the MRC was seen to be sufficient in terms of the kind of skills that I was gaining there. What I will say was I was never therefore embedded in the health department in the Western Cape. I relied quite heavily on my fellow college students at the time. We used to hold a weekly tutorial group where we really prepared and trained each other on important facets. So there were a couple of modules I needed to do, but otherwise my MPH was considered sufficient. I did the diploma in occupational medicine or in occupational health. And I wrote the final exams, but I did that all as a supernumerary registrar whilst working at the MRC, which I don't think is possible anymore.
Yeah.
And so then the question is, what did I gain in addition to if I just carried on with the MPH? I think I had good epi and stats skills. I think I had good understanding of health promotion. I think what I gained was having to really learn about the history and the way the health system is structured in a much more formal way. But the contacts and the colleagues and those networking points were what I really gained out of it. The exam itself, I mean, I examine now, so I do think that certainly in my day, the environmental health side of things was very limited. And I know that there are areas where we're trying to improve upon. I think I'll stop there, take a breath.
Thanks, Nandi. So I think that's very interesting, because I think you're one of the few people who recognize in medical school that public health is even a pathway. As you say, we get a paltry 5 weeks, and med students being med students would pay very little attention to it because, it's competing with cardiology and surgery or whatever the rotation is at the time. But I just want to reflect on a few things that you said is that firstly around the MPH and the MMed and or the registrar time. And it's quite often a discussion or a question from a lot of people, because there's quite a few people who do the MPH, myself included, and then go on to do the reg time, and people, as you say, grapple with, do I need the skill? I think maybe the difference in your situation was that you were able to at least get practical experience while you were doing the MPH. Whereas a lot of, I can talk about myself included, a lot of people are doing the MPH, but maybe working in a clinical role and not really, don't know how to translate those skills or don't have the opportunity to translate those skills. And so that is where maybe registrar time does help, is because you are doing the work while you are busy doing, your studies. And then to the point around the OCMED, I think this is just for anyone who's watching and is a bit confused about occupational medicine. So just to say that occupational medicine is also a registrar program. It is currently under the College of Public Health Medicine. So it is, we have public health medicine, registrar training, occupational health training, occupational medicine training. And but they are run as two sort of separate degree entities within the college. Having said that, though, part of the training for public health medicine specialists does include occupational health. So it's not as in depth as somebody, who is undertaking occupational medicine training, but you have to have an awareness of occupational medicine, and there is usually a rotation into occupational medicine if you are at the, if there are opportunities for you to do so, but it is part of the competencies of a public health medicine specialist. And then to the point of the supernumerary, there are, I think, as you say, you were fortunate, and I think also, the college has evolved a bit in the way training is done. There are still some supernumerary registrars, so that is a potential to be able to work in a public health setting, and then sort of do the exams at the end, but not all of the universities do offer that. So I don't want anyone to think that you can definitely do that. It is one option, but it's not always there, and it's not always easy
I think it's important. Perhaps it sounded fairly seamless to do what I did, but in truth, even before I went to Australia, I think it was a couple of years, maybe I came back from Australia. I was still working clinically in Australia, and I went to find out how to do community medicine. There was very little information, and I remember there was one option of getting some sort of 1-year fellowship, just to do it almost at an MO level, whereas now I think you do have that option of, maybe if you're fortunate, being able to use your community time to some degree to do it. It was sort of something like that you could tie yourself onto a project if there weren't registrar posts. So I remember just sort of giving up at that stage because there was no clear path at all. So I think from that point of view, it's much clearer. On the other hand, I had a lot of flexibility because it was then evident to me after I got my college exams that I still really wanted to pursue the research route and the application of research into my field, which is the clinical guidelines. And so at that point, it was more meaningful for me to go ahead and actually do a PhD as well, which is certainly not something you would necessarily be required to do if you were going to be only in the operational public health specialist space. But Atiya, I mean, I think you and I, we're both passionate about public health medicine. And I think we know that Virginia's did her wonderful PhD trying to really unpack some of this. I do think if you've gone through medical school, you do feel in your heart, and I'd like to have some more some more evidence to be able to say this rather than just a feeling, but that you want to have a recognition amongst your peers. And this is something that it does give you. You are a bona fide specialist. And I think that's why perhaps thinking about not saying public health medicine specialist, but public health physician is a good way of perhaps trying to articulate that. I think we have a long way to go in terms of conscientizing our colleagues who are only in that clinical space. But I think COVID revolutionized that because I think it became very evident of the thinking skills, the sound foundation in epidemiology and biostats that is required to actually make good healthcare decisions. And I think we gained enormously from that because there were some very active public health medicine specialists during the pandemic. And I think clinicians noted it, and the respect is increasing.
Yeah, that's an excellent point. And I think part of the rationale for this series of interviews that I'm doing, as well as the webinars that, around public health training, is because COVID has highlighted that public health is a potential career option that is interesting and has, many different subfields within it, that there is a potential to translate clinical skills or, whatever skills that you do have into public health. And so I do think it has come to the fore as something that provides real value within the health space. And, the discussion around public health or an MPH versus an of specialization in public health is one that's been going on for a long time. And I know there are some sensitivities around that discussion. But I think as public health specialists, like you say, we are glad to be recognized as specialists, but we do not see ourselves as our training is certainly different and more steeped in experiential learning, because
Yes.
compared to an MPH, where you may just be learning the theory and not necessarily the application of it. But we also recognize that it takes many, and the world has too many problems for it to be addressed only by public health medicine specialists. There's many things, and we do need people from various backgrounds. I mean, one of the interviews I was doing, I was discussing with a colleague who's from a communications background, and we were talking about the WHO building blocks and how there's finance and HR, and you could come from that field
Yes.
into health, or you could come from within health towards, human resources for health. And we really do require all of the different people to be able to bring those different lenses. But there definitely is a benefit in the training nowadays, in that it is more steeped in actually doing the work within the service. So when you come out of your training, you have those practical skills that you can hit the ground running with.
And maybe it's worth saying that what the college also offers, which an MPH wouldn't do, is ultimately a community of practice. So I think it's really important, you stick with those individuals who you've studied with and been examined, with, and I think that that's important. And we have very few opportunities to actually be with our tribe, to actually come together and actually, because we all have a shared understanding. And so that's a very special thing, which is why there are conferences and so on. But when it's something really broad, it's different to when you actually create a space just for individuals who've actually done both the medical degree and in the specialist public health.
So you mentioned that you then went to pursue a PhD. So let's maybe just chat about that as well. What was some of, because then you had, your specialization, you had your MPH. And I mean, I'll say this now, because I'm also grappling with whether or not I should be pursuing a PhD, because I'm not in an academic space. I'm affiliated to universities. I do some teaching, some supervision, but I'm not a pure academic. And so I think, some reflection around, what are the decisions around a PhD? What do you feel it added to your career path would be helpful for anyone that is watching.
Yeah, well, there are two answers. The one is very simple, that within the Medical Research Council, you will not progress without a PhD. So that was the first thing. And I found myself at relatively soon being an acting director. But to be a full director of a unit, you required a PhD. I think that's shifted somewhat, but that was a very strong message that I had received, that even though I was doing the work of a director, I was not going to be considered a director because I didn't have a PhD. Having said that, prior to that, I had explored, and this is what I think it's important for people to know. I had explored several different possible PhD topics. We got funding for a very large TB trial, for a variety of reasons that then didn't go ahead in the way that we'd hoped and planned. And so I think anybody who pursues a PhD usually will have a couple of failed attempts. But it became apparent to me that if I did want to pursue a PhD, it needed to be because I wanted to do it. And I was very interested. I was working in systematic reviews and evidence synthesis and how clinical guidelines are made. And I realized that there were some foundational principles, both cross-cutting in epi and stats, but particularly related to clinical trials and conducting clinical trials, that I was lacking. And that really, there wasn't much opportunity for gaining those skills here. So I was very, very fortunate and received a Nuffield medical fellowship and was able to do my PhD in, protected time overseas. And that was wonderful because I could do it in a finite period, using a lot of the work that I was anyway building on at the time. So it was an extraordinary and very special time because I did it full time, to be fully immersed in a topic and to really build the knowledge that I knew that I lacked, because I didn't come from a statistical or an actuarial background, and there were a lot of methodologies that I needed to spend more time. I was just sort of applying things, but without that deep level of understanding. And so that was what it gave me. And I think, it as I said, it didn't always feel intentional, but when I look back, I can actually see how the steps came. I think it's much clearer now. We have the whole concept of clinician scientist. We have, Bongani Mayosi absolutely spearheaded the growth of doing PhDs, of having heads of department who have both, in the clinical setting, that as well as the research competency, to try and really build a greater, I don't want to say academic, but perhaps a theoretical understanding of why we do what we do.
Yeah, it's a really great point. I want to pick up first on what you said. You said it a few times about, it didn't seem intentional at the time. And I think that's something that I also reflected on in my interview, was that for anyone who is watching, you may see people and you think, oh, they had it figured out, but it's easier when we are looking retrospectively to see how things converge. And they do converge because naturally, as a human being, you gravitate towards certain topics, you gravitate towards certain ways of being. And so when you look back, you'll be like, oh, everything kind of led me to this point. But it is a mixture of circumstance and the decisions that you make based on knowing you and knowing or your circumstances at the time. But then to the point around, I think that the PhD, I think that what you said was quite valuable in that it allowed you to get steeped into an area. When we do public health medicine, and one of the really great things about public health medicine is that you are trained very broadly. You do health management, you do epidemiology and biostats, you do OC health, like I said, you do different sort of disease entities, so communicable, non-communicable, responding to outbreaks. And so, yes, you can go sort of anywhere or kind of do any projects. And I'm sure you as a consultant also, Nandi, realize like you'll be doing work on policy here, and then you'll be doing some data analysis. But there is also value in steeping yourself or being seen as having knowledge and skills in an area. And that's, I think, what the PhD allows you to do, to sort of steep yourself in whether it's a methodology or whether it's again, human resources as a topic, or, it really allows you then to engage with it in a different way.
I would completely agree with that. And in my case, it was very much about learning the methodological skills. And then those can be applied across a very broad range of topics, which is where the medical degree comes in. Because in my work with the World Health Organization, I primarily began working in the HIV/AIDS space, in clinical guidelines, but I've worked on everything from, the integrated care of the older person to school health, with some communicable and non-communicable diseases thrown in along the way. So, and each time I've used those foundational applied methods in order to inform, the guidelines.
And I think to the point of one of the other colleagues made in one of his interviews that, this public health may seem to sometimes to, especially our clinical colleagues, that it's not steeped in science as someone who is dealing with cardiology or surgery, but it is. And those skills are transferable. So you learn a certain approach, a certain framework, a certain way of doing things, and you can transfer that across different disease entities, disease programs, challenges that you may encounter. So Nandi, I have two more questions for you. The one is just, I suppose sometimes it's difficult to answer, but people grapple with, what does someone's day look like? What are you actually doing as a public health specialist or a clinical epidemiologist? So what are some of the, I mean, you obviously, may not be able to give too much detail because, some projects are obviously sensitive, but what does the work look like for you?
Okay. So, I mean, I think 10 years ago, I was actually conducting systematic reviews, drawing all the data together, coming up with reports. I tend to do a lot more oversight now, so supervision of others doing that. I do a lot of strategic thinking with colleagues at the WHO about what are the best questions that we need to ask, how best are we going to actually run a particular meeting. And then actually quite a big part of the work that I do as a consultant is actually facilitation in the guideline space. So it's getting a disparate group of individuals together and using, again, the applied methods to come to a point where you decide whether or not one should or shouldn't recommend a particular intervention. So those are a lot of the softer skills. With my MRC work, obviously I work with other colleagues, but we input into policy, but there are then individuals who are running specific research projects, and I'm usually engaged in the clinical trial space. So it will be about helping somebody develop their protocol for a trial. It'll be about sitting on a data safety and monitoring board. It can be, at the moment, hopefully going to publish something on this very soon. We've actually been applying a UK-based carbon tracking tool on the emissions from clinical trials. So that's been actually a lot of me doing hands-on stuff and actually, getting in on the Excel and realizing, actually I need to do a REDCap database. So those very key kind of research-related questions. So it's very diverse. And particularly in the consulting space, I work on discrete projects. So you'll have a beginning and an end, and then it's done and you move on. And I think that's one of the key things. And I was talking to you about the piece that I've put together about what being a consultant is all about. But I think if you're someone, and this can be very difficult as a public health practitioner, if you want to see what you have developed be implemented, being in the consultancy space isn't necessarily for you, because you will come in, you'll assist, you'll move things along, and then you need to step back. You need to let other people take the credit, and you need to let it go off there, and you're not responsible for it being implemented. And that can be somewhat difficult. My MRC work allows me to see projects all the way through, from beginning through to end, through to dissemination, through to, public interface policy.
So that's partly why I went into consultancy, because I do not have the stamina for long-term academic projects. So that's the other side of the coin. If you feel like, I want to stick discrete projects, then consultancy is a good way to do that. But to the point that you were making around sort of the different activities that you've been involved in, I think that's also an important nuance for people, because there's, again, within public health, different types of activities. So you could be, if you were the type of person who really is not interested in stakeholder management and facilitating groups, you could be a technical person and you sit with the data and you analyze the data and you write reports. And there's people who enjoy that and love that and are really good at that. And then there's people who like to discuss things and convene stakeholders and come to consensus. And that is sort of another end of the spectrum. And so, again, it's about finding that niche. And in the beginning, as with all jobs, you kind of have to do, when we were interns, you gotta do everything. You gotta go speak to the radiologist, because you have to book the CT scan, and you have to take the bloods, and you do everything. And then as you go, you can hone towards your interests and the things that you are good at and like to do. All right, so my last question then is really around, and I know you've dropped little bits of it in the discussion, but if you were looking at, yourself 20 years ago, or if you were, someone who was in your position where you were trying to grapple with like next steps for my career as a young professional, what would you advise them if they were interested in public health and thinking around, what does this mean for them as they progress?
It's a hard question, because I think it's very individual. But I think, as I've told my story today, just in listening to myself, there were a lot of lucky breaks along the way. And those lucky breaks ended up coming down to the people who supported me and helped me along the way. And I've had two fantastic mentors. One of them was my PhD supervisor, Mike Clark from the University of Oxford, and the other was Jimmy Volmink, who's was the Dean of the Faculty of Health Sciences, but was worked in Cochrane alongside me as co-director. And, really, without them, and also I will say other MRC staff as well. In fact, Merrick Zwarenstein, who's subsequently gone to Canada, and Charles Parry, who's shortly to retire, who actually was the person who gave me my first research 3-month job. I think I've just been extremely lucky to have individuals who had faith in me, and were willing to support, particularly when it came to being referees. And I think that perhaps is something, it sounds terribly strategic. And again, I don't think 20 years ago I thought about it like that. But it is important to identify who are the people out there who have the kind of job that you would like to have, and are they the kind of people you'd like to work with, and how can you get yourself to a place that you can interact with them. And I think you can be very open and upfront about that sort of need. And so I think, seeking out the right people to advise you, and just on that score, when it doesn't feel right, it isn't right, because I've had some very poor advice as well, which now that I'm older, I look back and I realize it wasn't about, they weren't thinking about the best for me, they were thinking about the best for them. So also have a sense in yourself when you feel that something doesn't fit right. It should feel good. The career is so multifaceted, and as you say, there's room for everybody, regardless of your background skills. And I think that what I've really noticed along the way is what great people are who have a public health perspective. Really, that broader approach to the world, the compassion, it really comes through. So I don't know if that's necessarily answered your question specifically, but I think it's about finding the right people. And if you're fortunate, you will find it might always be senior people, it might be your peers as well, who can give you really good advice.
That's really great, Nandi. It again, I think, reflects some of what I've been discussing as well for young emerging professionals. And I know it seems, so I like what you said about thinking about who it is that whose career you may want to emulate, or someone who you like their approach to public health. And it's not to say that, sometimes people are busy, you'll send them an email. I had an experience like that as well, where I sent one of my colleagues and I was like, an email, and I said, please, can you unpack with me something that I needed to unpack? And they didn't get back to me. And don't try and take it personally. In my instance, it just happened that they missed the email. When I saw them a few months later, and I was like, hey, I sent you an email. And they were like, oh, we're very sorry. Sometimes people are busy. Sometimes they are, especially people who are doing really great things. Obviously, lots of people want to engage with them, but that doesn't mean you shouldn't try. One of our other colleagues in her interview gave some really great advice around start engaging in the public health spaces. There's the Public Health Association of South Africa. You can try and find meetings where public health people are discussing topics of interest, And that will allow you to become familiar with who. Sitting there and just Googling random public health people may not assist you, but having that, but having some insight into the field and
Yeah.
the
Yeah.
people will really help. And I think that is, it's like you say, you didn't want it to sound strategic, but that's the reality of the world, is that we lean on other people, and sometimes those people are the conduits to where we need to go next. And so it's not self-serving in a way. It is just the reality that you have to connect with people and you cannot do things on your own. So I think that is some really, really great advice. And as you say, peer mentors as well. It's not always senior people. Sometimes you just need someone to say, yeah, I know this sucks, or or this is, and if you've worked in any environment, you'd gravitate towards certain peers and colleagues. So that was very helpful. Thank you. Any last, I'm covered, any last reflections that it would be important for someone to just think about?
I think the value is in knowing that the work you do matters. And I think you have to ask yourself, are you doing what you think is good for you and good for the world going out there?
Yeah. Thank you, Nandi. I think that was a really beautiful point to end the conversation on. I'm certain that whoever watches this is going to find some gems of wisdom in there, and hopefully it will allow them to think differently or more deeply about their career and their journey going forward. So thank you again for your time. We really appreciate it.
My pleasure. Thanks.